So my name's Kate Gibson. I'm an associate professor at Virginia Commonwealth University School of Pharmacy, and today we are going to talk about chronic care in cardiology, so really focusing on our outpatients. So we're going to talk about chronic care, and then Dr. Finks will come in after me, and she will go over acute care, so what we do with hospitalized patients. Thank you. I have no financial relationships to disclose. And you can see our learning objectives for you here. These are in the workbook chapter. You'll note there's 5 objectives, but for the sake of time today, we're only going to go over 4 key disease states. So please make note that we will not be discussing coronary heart disease in detail in today's session. There is a section in your chapter. Dr. Finks will cover some of those highlights in her session as well, though. So we're going to just get started with heart failure. This will be kind of the longest piece today. As you all know, heart failure is a complex clinical syndrome that's characterized by the inability for the heart to appropriately fill with or pump blood. So in our patients with heart failure, our goals of therapy are to minimize their symptoms, to reduce progression of disease, and of course to prevent mortality. When we talk about our chronic heart failure patients, we talk about them based on their ACC-AHA stage and their New York Heart Association classification. So our ACC-AHA stages describe the degree of structural heart disease as well as associated symptoms. And our New York Heart Association is really focused on functional class. So does our patient have symptoms at rest? Do they have significant limitations in their activities or slight limitations? The majority of our trials and the majority of our drugs really focus on stage C folks, so they have structural heart disease with either prior or current symptoms, and they can sort of fall anywhere in this range of no limitations to symptoms all the way at rest. The other important question you'll want to ask is, what is my patient's ejection fraction? And we typically, historically, have talked about these patients as either having heart failure with reduced ejection fraction, meaning an EF of 40% or less, which is the most common cause is CHD. And so this is characterized, think of this as more of like a pumping problem. The heart is having trouble pumping blood adequately to the body. As opposed to heart failure with preserved ejection fraction. And so these patients have an ejection fraction of at least 50%. The most common cause here is longstanding hypertension resulting in strain on the heart. And so this is more of a filling problem. The heart is struggling to relax and fill with blood appropriately. I think it's my hair, I'm sorry. I want to note that brand new heart failure guidelines came out after my slides were due. So I tried to put in a few key updates here, but they came out at ACC in April. And so these guidelines do also provide recommendations for 2 additional classes based on ejection fraction. And those are patients with heart failure with mildly reduced EF and heart failure with improved EF. So I've added a couple extra slides on that. My updated slide deck is available for download, but it did not make it into print because this is hot off the press. And there's also an errata posted online in the portal. And so you can also download that to see my updated algorithms. And we're going to start by talking about heart failure with reduced ejection fraction, and the guidelines really specifically focus on those stage C patients. This is our new treatment algorithm. So this is going to replace the one that's in your workbook and in your printed version of your slides. I don't think this is really surprising. We kind of already knew all of this, but these recommendations are now incorporated into the guidance. So historically, we talked about we need to start an ACE or an ARB or an ARNI and a beta blocker. And that was kind of our backbone of guideline-directed medical therapy, and we added on therapies from there. Well, now the new guidelines say we know we have 4 drug classes that result in improvements in mortality. So we're actually going to call our backbone of therapy all 4 of these drugs. So our ACEs, ARBs, ARNIs, our beta blockers, and then also our mineralocorticoid receptor antagonists. So this is like spironolactone and eplerenone. And then 4th are SGLT2 inhibitors, which we keep hearing so much about lately. So these 4 drugs are our life-saving drugs, and they are all a backbone of therapy. We want to try to get all of our HFrEF patients on these drugs. And the new guidelines do say that we would pick the order that we add these drugs in, sort of based on an individualized treatment plan for our patients. So less prescriptive about adding them on in the exact same order as the trials, although we are still seeing that being done in practice. And then the 5th drug class at the top is a diuretic, usually a loop diuretic. Anytime you have a heart failure patient with fluid overload, of course you're going to diurese them. This is not a life-saving therapy, but it is a first-line therapy for anyone who needs it. So we're going to get these 4 drugs on board plus a diuretic if needed. And then once we do that, we can move on to additive therapies. So now what we're going to do is break down those first 5 drug classes in a little more detail. Starting with our ACE inhibitors, I'm sure you're all very familiar with these. They block the production of angiotensin II, and so they help with patient symptoms, they help prevent cardiac remodeling, and they're also known to have a mortality benefit. My little banner on the bottom is telling you that these are for patients with an EF of 40% or less, and now the guidance specifically says those ineligible for an ARNI. So ARNI being our sacubitril/valsartan combination product. The guidelines do specifically say now we do prefer that drug over an ACE or an ARB whenever possible, but ACE inhibitors are reasonable for patients who can't be on that. We'll start low and titrate slowly every 1 to 4 weeks with these drugs, and we'll titrate to the target dose, which was shown in clinical trials to have the greatest mortality benefit. We'll talk about that. Of course, these are antihypertensive, so we're going to monitor our patient's blood pressure, and then also checking labs. So these can cause kidney injury, acute kidney injury, so monitoring creatinine, and then also monitoring potassium because they can cause hyperkalemia. The most common adverse effect that you'll see with these drugs is that dry cough, which is due to bradykinin, and rarely angioedema, so monitoring for those as well. This is a table about ACE inhibitor dosing in heart failure. These are the 6 agents that have been shown in clinical trials to reduce mortality. And so in terms of preparing for your exam, what I would really recommend, and I know it's not fun, but I would really recommend memorizing this target dose column, because that's always going to be some low-hanging fruit if you have your patient on an ACE inhibitor, but they're not to that dose that was shown in trials to improve mortality. That's always going to be a reasonable option when you're picking your answer choices, is to increase that dose. If it helps at all, I listed these drugs in alphabetical order, and kind of roughly speaking, the total daily dose goes from highest to lowest. So captopril, 50 TID, 150 milligrams total a day, all the way down to trandolapro, which is 4 milligrams daily. So roughly speaking, that might help you with your memorization. We also have ARBs. These have not been proven superior to ACE inhibitors in trials, but they are a reasonable alternative, especially in patients who can't tolerate an ACE, most commonly because of that cough that can be really troublesome. So these drugs kind of have the same monitoring and the same considerations as ACE inhibitors, and they also have a starting dose and a target dose. And again, I would recommend learning these target doses. The good news is there's only 3 that have been studied in trials in these patient populations, so a little bit easier to memorize here. And this time, the total daily dose, if it helps, increases as we follow our alphabetical order. So starting with candesartan, 32 milligrams a day, all the way up to valsartan, 160 milligrams twice daily. Okay, so I already hinted and mentioned this ARNI before, sacubitril/valsartan. This is the newest drug kind of in this drug class. You know that valsartan is an ARB already. What is sacubitril? Well, it is a prodrug, and then its active form inhibits neprilysin. So what neprilysin does is it increases our levels of endogenous natriuretic peptides. I know when we think about things like BNP, we think, oh, that's bad, but do remember that BNP is the body is trying to do the right thing. It's trying to help with heart failure. And so our endogenous natriuretic peptides will help promote natriuresis, diuresis. And so this is one of the reasons these drugs are really helpful. Again, the new guidelines say that ARNI is the preferred first-line RAS-blocking agent. So we can start this right away. We don't have to make the patient try an ACE or an ARB first and then switch them. We can start the ARNI right away. If your patient's already on an ACE or an ARB, we do want to try to get them switched to an ARNI if at all possible. Of course, you know the main reason we might not be able to do this is usually due to cost, but it is something that we want to try to be a goal. And the reason is, based on our Paradigm HF trial, this drug was compared to enalapril, and there were mortality reductions compared to enalapril. So this is an important kind of step for our patients. Something really important to keep in mind if you are switching your patient from an ACE inhibitor to an ARNI, or vice versa, anytime you're going ACE to ARNI, you need to allow a 36-hour washout period, because if we dose the drugs closer together than that, we see an increased risk of angioedema, and so we certainly want to avoid that. Okay, so that kind of covers our first box. We want to get all of our patients preferably on an ARNI, but maybe an ARB or an ACE. The next box is our beta blockers, which I'm sure you're also very familiar with these. So these block the effect of norepinephrine and other sympathetic neurotransmitters on the heart, and the reason this is helpful is they help decrease ventricular arrhythmias, decrease cardiac hypertrophy, and then they can also decrease vasoconstriction, and of course they lower heart rate. When we're thinking about the different drugs in this class, carvedilol is also a little bit unique in that it has some alpha blockade, and so that is going to result in more significant blood pressure lowering than the other drugs, which may be a good thing for your patient or it may be a bad thing, depending on kind of where their blood pressure is lying. These drugs have been shown in trials to decrease mortality and hospitalizations as well as improve symptoms. And we also know that the mortality reduction is sort of proportional to the dose. So beta blockers also have a target dose, and we try to keep increasing to our target dose in our patients. These are indicated for any patient with an EF of 40% or less unless there's a contraindication. So just like ACEs, ARBs, and ARNIs, we'll kind of start low and increase our dose slowly, aiming to achieve our target dose in 2 or 3 months. And our patients might start to notice improvements in their symptoms after several months. The key thing to remember with beta blockers in HFrEF is that there are only 3 agents that were shown in clinical trials to reduce mortality. So when we are picking our beta blocker, we need to pick one of these 3. We have bisoprolol, we have carvedilol, and then we have metoprolol succinate. So note metoprolol tartrate is not included in this trial, in this slide. It's specifically metoprolol succinate. Here are our agents and then our starting doses, and once again our target doses. And I do once again recommend that you learn these target doses, because again, if your patient is on a beta blocker but not yet at the target dose, we do want to try to get there if we can. So I know you're probably looking at this and going, I don't typically see a whole lot of patients on metoprolol succinate 200 milligrams a day. And you're right, we don't. A lot of the times patients with heart failure, they're on so many different drugs, so many of them lower blood pressure, that sometimes we can't get to these doses, but we are gonna try if we can. And so we're really doing a patient a disservice if we don't try to get there, because we know the mortality reduction is greater with higher doses. We will, of course, because of these concerns, monitor for blood pressure and heart rate. We'll also monitor for edema, and we do generally avoid starting a beta blocker in a patient with a current kind of heart failure exacerbation or with current fluid overload. We typically want to wait until they do not have that going on before we start or increase our doses. And then the main side effects are things like fatigue and weakness, which do usually spontaneously resolve as patients continue therapy. All right. Third, we have our aldosterone antagonists, or sometimes called mineralocorticoid receptor antagonists. These are our medications are spironolactone and eplerenone. Between the 2 of them, they have been studied in New York Heart Association 2 through 4 heart failure with reduced ejection fraction. So sometimes people call these potassium-sparing diuretics. It makes sense that they're going to decrease loss of potassium as well as magnesium and also decrease sodium retention. And they also help eliminate catecholamine potentiation, and they block fibrotic effects on the heart. Because of this, they've been shown in studies to decrease symptoms, decrease hospitalizations, and decrease mortality. So these are another drug that are included in our backbone of therapy that we want to try to get all of our HFrEF patients on. So historically, in the trials, these have been added on to ACE inhibitors and beta blocker therapies. Again, remember our new guidelines give us a little more flexibility to sort of pick our order based on what is best for our patient. But in the studies, that's how it was done. And so they are indicated for any patients with New York Heart Association 2 through 4 with an EF of 35% or less. And then our patients with less symptoms also in the studies had a history of cardiovascular hospitalization or elevated BNPs. And then also based on a different trial, if your patient has a history of an MI and an EF of 40% or less, that's another indication for these. So aldosterone antagonists, we want to try to get them on anyone that we can. We do need to look at our patient's creatinine and potassium before starting these drugs. If you have a male patient with a creatinine of more than 2.5 or a female with a creatinine of more than 2, then we do not typically want to start these drugs, or if their GFR is less than 30. So this is because as we have more renal dysfunction, we have more potential to accumulate potassium. Hyperkalemia is a very real concern with these drugs. And also for that reason, we don't initiate these if our patients have a potassium of 5 or greater at baseline. But they will be a good therapy for most patients with HFrEF. Here we have our dosing. You'll notice that, again, because of this hyperkalemia risk, the dosing is really kind of based on our patient's GFR. This is not really like strict target dosing. These are just the general recommended initial and maintenance doses in the guidelines. So I would just feel comfortable with these, but not like ACEs, ARBs, and beta blockers where we very strictly need to try to achieve these doses. So you can see eplerenone and spironolactone here. For monitoring, again, because the risk of hyperkalemia is so high, we check potassium and creatinine a couple of times within the first week, and then we check it monthly for the first 3 months, and then every 3 months thereafter. And if at any time you make some other adjustment to your patient's drug therapy that might result in hyperkalemia, so maybe you start an ACE inhibitor or you increase an ARB dose, then we need to start this monitoring all over again. Hyperkalemia does occur in up to 20% of patients in clinical practice, so that's why we monitor this so closely. The main side effect that we hear about is gynecomastia. Of course, this occurs more commonly with spironolactone because spironolactone is less specific to these receptors and does have some activity on progesterone and androgen receptors as well. So if your patient does experience that, it may be reasonable if they're on spironolactone to switch them to eplerenone. You probably see more people on spironolactone, and that's for cost reasons, but that's something to consider. All right, and our fourth life-saving drug in our backbone of therapy seems to be what everybody is talking about these days is SGLT2 inhibitors. So as you know, these drugs were originally studied as anti-diabetics, right? And we found in studies that they also had a lot of really beneficial cardiovascular and renal outcomes. And so for that reason, these have been added to the heart failure guidelines irrespective of your patient's diabetes status. So even if they don't have diabetes and they have HFrEF, we want to try to use these medications. So in addition to their glucose lowering abilities, they also have other mechanisms. They promote natriuresis, diuresis, they help with endothelial function. They have a lot of proposed mechanisms that may be beneficial in heart failure. And so in our recent trials, we have seen a reduction in mortality in heart failure with reduced ejection fraction patients who take these medications. So you can see your dosing here. It's a fixed dose. That's nice. We don't have to titrate to a specific goal dose for both dapagliflozin and empagliflozin, 10 milligrams a day. The renal function cutoff is a little bit different in heart failure than it is in diabetes, and that's because we think that the heart failure benefits are preserved even at lower GFRs as compared to their ability to lower glucose. So for empagliflozin, our cutoff is 20 milliliters per minute. It wouldn't be an updates in therapeutics meeting if I didn't also have an update to this slide. For dapagliflozin, they've actually lowered the cutoff to 25 now, and that's based on some new data from new trials, and it's been incorporated into the new heart failure guidelines. So these are going to be important therapies. They were studied as add-ons to ACEs and beta blockers, but again, we have a lot more flexibility now in our guidelines to start these whenever we feel is most appropriate. And so most patients are going to be good candidates for this as long as their renal function allows. Because they are anti-diabetic drugs, we do monitor hemoglobin A1C. And because they work by wasting glucose in the urine, we did see more genitourinary infections in the trials, so we'll monitor for that as well. They do have some diuretic effect, so we're going to watch our patient's creatinine and watch for volume depletion or acidosis, and then of course blood pressure and orthostatics, because we do see slight blood pressure reductions with these drugs as well. Okay, so those are our 4 life-saving therapies and our kind of backbone. And then we also have diuretics, which are also first line for anybody who needs them, indicated anytime you have a heart failure patient with fluid overload. Loop diuretics are the preferred diuretic drug class. That's because they're the most effective at diuresing patients. Again, they reduce symptoms, but not mortality. So we'll start with a low dose. If our patient is acutely fluid overloaded, we'll titrate that dose with a goal of the patient losing about 0.5 to 1 kilo of weight a day. And then once we maintain, or once we reach that kind of euvolemic weight for our patient, then we'll adjust the dose. We'll go down on the dose to help maintain them at their dry rate. So we do have to monitor electrolytes. Of course, these drugs can cause potassium and magnesium wasting, so we're going to try to supplement potassium to keep it at least 4. Sometimes we do that with an actual potassium supplement. Sometimes we can do that by increasing our doses of our MRAs or our ACEs, ARBs, ARNIs. And also monitoring creatinine to watch out for the potential for pre-renal acute kidney injury. Combination therapy may be required to achieve adequate diuresis, especially in later disease. And so the most common combination therapy that we use is add-on of a thiazide diuretic. So I've listed here for you just kind of some typical dosing of our loop diuretics as well as our thiazide diuretics. I think you should kind of be comfortable with these doses, but I don't think you need to memorize this chart for your exam. I will kind of highlight, if you look at the duration of action, our duration of our loop diuretics is not that long. And so it's pretty common for you to see patients taking furosemide 2, maybe 3 times a day. We typically try to avoid bedtime dosing so they don't have to get up all night going to the bathroom, but sometimes you'll see these dosed more than once a day. And then add-on therapies include things like hydrochlorothiazide, metolazone, and chlorthalidone. Okay, so we've just gone over the top row. We want to get our patients on these drugs. We want to get them titrated to the target dose if it's a drug that has a target dose. And once we've done that, we can start exploring add-on therapies for further reductions in symptoms and things like that for our patients. So we're going to go through each of these 6 potential add-on therapies. And again, not all of these are covered in your printed workbook, but they are all in the online version. The first drug is hydralazine isosorbide dinitrate. So we know about the components of this drug. Hydralazine is an arterial vasodilator. Isosorbide is a venous vasodilator. This is a combination product which together can help reduce preload and afterload in our patients. The main place in therapy here is based on the AHEF trial, in which patients who self-described as African American and had a New York Heart Association class 3 through 4 HEF-REF had a decrease in mortality and a decrease in hospitalizations when this drug was added to what was then the backbone of therapy, which was an ACE inhibitor and a beta blocker. So the things to kind of keep in mind with this drug, that's kind of the population that you would consider using it in. You don't see this used all that often, and a lot of that is because of cost and also because of pill burden, especially if you're going to split this up into the individual components. Sometimes you're committing your patient to 9, 12 extra pills a day, and so that's why we don't see that commonly. But it is an appropriate recommendation, an appropriate drug to keep in mind. The next one is digoxin. We know based on the DIDGE trial in HEF-REF patients that digoxin helps with reducing hospitalizations and reducing symptoms, but again, it does not have any mortality benefit. Usually, if we're going to use digoxin for heart failure, a dose of 125 micrograms a day is usually enough, maybe even lower, maybe even every other day in patients with very advanced age or impaired renal function. Digoxin is a narrow therapeutic index drug, so we're trying to target a serum concentration of less than 1. And so we do know that higher than that, we see a lot more toxicities, and the risk of toxicity increases with age, renal dysfunction, and then hypokalemia and hypomagnesemia. So also important if you're using digoxin to make sure we're optimizing electrolytes. The other thing to keep in mind is digoxin has so many drug interactions that we have to watch for. I think this could be something that might help guide you maybe away from digoxin in a patient case on the exam. So this is not an all-inclusive list by any means, but a couple of kind of the main drugs that you might see in some of these patients with interactions include amiodarone and dronedarone. With both of those agents, we have to reduce our digoxin dose by about 50%, and then also verapamil. Most of this is through P-glycoprotein drug interactions, but there also are some CYP3A4 interactions, and then of course the potential additive effect of bradycardia from multiple drugs that can have AV nodal blockade. So regardless, digoxin is an option in our patients with an EF of 40% or less who are still having heart failure signs, symptoms, or hospitalizations despite optimizing that top row in our algorithm. Kind of similarly, we have ivabradine. So ivabradine, as we all probably remember from pharmacy school learning about those funny channels in the SA node, this drug blocks the funny channels, and so essentially what it does is it reduces our heart rate. So its place in therapy is to use as add-on therapy to maximally tolerated beta blocker therapy in folks who may still benefit from further heart rate reductions. So really the thought here is this one doesn't lower blood pressure, so sometimes maybe we could add it on to a maximally tolerated beta blocker therapy if we still need additional heart rate reduction. So it was shown to reduce hospitalizations in its study because of that. Because it causes heart rate reductions, you cannot start it if your patient's resting heart rate is not at least 70 beats per minute. Watch for that. And then, of course, monitor for bradycardia. It is also associated with atrial fibrillation, so watching for that, and then phosphenes, which are visual disturbances. Okay, this is a new slide, and it's, again, in your online version as well as the errata posted. there are 3 other drugs or drug classes that are mentioned in the new guidelines. The first one is vericiguat, which is a soluble guanylate cyclase stimulator. And so this drug basically increases concentrations of cyclic GMP, which has a number of beneficial effects like vasodilation, natriuresis. It can decrease fibrotic effects on the heart. It can decrease cardiac remodeling. So it was shown in the Victoria trial to reduce the composite of cardiovascular death or hospitalization when used as add-on therapy to our GDMT. And it does have a target dose of 10 milligrams once daily. We'll try to titrate up to that by starting at 2.5 milligrams. And then the main things to watch out for here are the potential for hypotension as well as syncope. The guidelines do also mention that we can consider adding polyunsaturated fatty acids for our patients with heart failure. This is the result of a couple of trials that primarily found a benefit of polyunsaturated fatty acids in folks that have ASCVD, but that did extend to those heart failure patients in those studies as well. They don't give any specific guidance about necessarily which drug to pick, but they do mention both DHA-EPA combo products as well as our EPA product that does not have DHA. And we have recently started to realize that there may be a dose-related increased risk of atrial fibrillation when we use these drugs, so something to watch out for. And finally, they also talk about potentially incorporating potassium binders into your patient's therapy. The thought here is that we have all these RAS inhibitors, we have ACEs, ARBs, ARNIs, we have our MRAs. All of these can cause hyperkalemia. If we are not able to achieve our target doses or achieve the doses that help with symptom improvement because of hyperkalemia, if we add on a potassium binder, will it maybe help us get there? So we don't have studies showing clinical benefit, but the theory is that maybe that would be beneficial. And the guidelines specifically mention patiromer and then sodium zirconium cyclosilicate as potential options here. These can also cause hypomagnesemia, and then in the case of SCZ, they can also potentially cause edema, so monitoring for that as well. Okay, so that was basically this slide with a little bit more detail. So now we know what to do in our patients. We know we want to try to get this first row started, titrated to goal first, and then we can ask ourselves the questions in these blue boxes, and we can add on additional therapies for our patient that may benefit them. So that takes us to our first case. We have LS, who is a 48-year-old woman, and she has heart failure with an EF of 20%. She has New York Heart Association Class 3 with symptoms of dyspnea and fatigue. Right now, she is euvolemic and has no pedal edema. Her blood pressure is 112/70, and her heart rate is 72 beats per minute. She weighs 69 kilos. Her current meds include lisinopril 40, furosemide, carvedilol 12.5 twice daily, spironolactone 25, digoxin 0.125. You can see her labs are within normal limits, including a potassium of 4 and a creatinine of 0.8, and her digoxin level is 0.7 nanograms per ml. So our question for this patient is, which of the following approaches is best to maximize the management of her heart failure? Okay, yeah. So you picked answer choice A, increase carvedilol to 25 milligrams twice daily. I agree with you. We do know that higher doses of these drugs are associated with more mortality reductions. Answer choice B, we do have target doses with lisinopril, but this patient was already there, so there's no need to go up further. Answer choice C, thank you. Answer choice C, spironolactone. The recommended dose is 25 milligrams, so no need to increase this dose. And then increasing our digoxin dose to 250 micrograms a day, no need to do this. Our level's already 0.7, it's beautiful. And so all we'll really be doing is increasing the risk of toxicities without really having any additional benefit. Plus, she's not complaining of any symptoms today, right? Or wait, this patient is. Dyspnea and fatigue, excuse me, I'm getting my cases mixed up. But there's still no need to go up because we're already at our target dose. Plus, we want to optimize our guideline-directed medical therapy first before we start doing a whole lot in kind of the second part of that algorithm. Okay, so that was all heart failure with reduced ejection fraction. Next, we're gonna talk about heart failure with preserved EF, which, as you remember, is our patients with an EF of at least 50%. There is less clinical evidence for heart failure with preserved ejection fraction with regards to drug therapy. That's good news for us because this section will be a little bit shorter. But the therapies have really been focused on managing risk factors for this, like hypertension. And so our general treatment goals have been to control blood pressure, heart rate, and manage comorbidities. However, the newest set of heart failure guidelines do have a few more specific recommendations for HFpEF than previous versions. The first recommendation is the same. Systolic and diastolic blood pressure should be well controlled, and that anytime your patient with heart failure needs a diuretic, you should use one. The second recommendation is new. SGLT2 inhibitors can be beneficial in decreasing hospitalizations and cardiovascular mortality in HFpEF. This is based on our newer trials like Emperor Preserved. And then our third recommendation is that MRAs, ARBs, and ARNIs can also be considered to decrease hospitalizations. You'll note they don't specifically mention ACE inhibitors here. This is based on looking at some post hoc data where ARBs are the ones that showed more benefit. And so these are the recommendations and the guidelines of drugs that you can consider, very similar to our HFrEF drugs, but less strong evidence, less mortality reduction ability or things like that in HFpEF. I also told you we'd talk about these other two new classifications. The first one is heart failure with mildly reduced EF. So these are patients that fall in between that HFrEF range and that HFpEF range. And so the guidelines here recommend, again, use diuretics if you need them. The second recommendation is also we've already talked about this before, SGLT2 inhibitors can be beneficial at decreasing hospitalizations and mortality. So in our HFpEF trials of SGLT2s, we saw kind of the most benefit at the lower end of the EF range. So that's why SGLT2s are incorporated here. And then the third recommendation is basically saying any of the drugs that are useful in HFrEF may be considered to reduce the risk of hospitalizations and mortality here. But again, the evidence is not as strong and compelling as for HFrEF. And then finally, we have heart failure with improved EF. So these are patients that used to have HFrEF, and then for whatever reason, their EF has recovered, usually because you've done a really great job with your GDMT. And so now their repeat EF has gone up by at least 10 and is greater than 40%. And really the recommendation here is they probably got better because they were on the right therapies, so don't stop them. If you were using something for HFrEF that was beneficial, you're gonna keep it on. Okay, so that is heart failure based on EF classifications. Some other considerations for any patient with heart failure. There are a lot of medications that we try to avoid using in heart failure. So here is not an all-exhaustive list, but this is a bunch of the ones that you might see most commonly. You'll note things like NSAIDs and corticosteroids. They can cause, sodium and water retention, and so we want to try to avoid those. Our calcium channel blockers like diltiazem and verapamil are negative inotropes, so we want to try to avoid those as well. We know that our TZDs and pregabalin also have some calcium channel blocking abilities, so those are also things to avoid. Amphetamines, this makes sense. They activate the sympathetic nervous system, which is detrimental in these patients, so avoiding that. Cilostazol and antiarrhythmics, also things to avoid. They can have proarrhythmic effects in patients with heart failure. Exceptions here for antiarrhythmics are amiodarone and dofetilide, which we're going to talk about this in detail later. And then in general, hormonal therapies and nutritional supplements because they may have drug interactions or they may worsen risk factors for heart failure like hypertension. Okay, so our second heart failure case, we have JT, a 62-year-old male with HFrEF, EF 25%. He's class 2, euvolemic and stable. He has a history of an MI 3 years ago, hypertension, CKD, depression, hypothyroidism, and PAD. You check labs, you have a potassium of 4.1, creatinine of 2.8, which is his baseline, a TSH of 2.6, and his blood pressure is 128/74 with a heart rate of 72. His current medications include low-dose aspirin, simvastatin, enalapril 5 twice daily, metoprolol succinate 50 daily, furosemide, cilostazol, acetaminophen, sertraline, and levothyroxine. So the question here is which of the following is best for maximizing his heart failure management? All right, so I agree with you. Answer choice B, increasing enalapril to 10 BID is a great choice. That is our target dose for this patient, and there's no concerning creatinine or potassium values that would preclude our ability to do this. Answer A, there's really no need to switch from metoprolol to carvedilol on this patient, especially because they do not need additional blood pressure lowering. So that is not an appropriate choice. Now, if this were titrate your beta blocker to gold, then it would have been an appropriate choice, but there's really no need to switch. C, adding spironolactone. Unfortunately, this patient is not a candidate for spironolactone because of their baseline creatinine. And then adding digoxin is not necessary in this patient because this is add-on therapy in patients who are already on optimized background therapy and who are still having symptoms. Do you notice anything in his medication list that concerned you? Yeah, good. So we might also want to try to address that in our clinic today, is getting cilostazol off, because that is a drug that is not recommended for use in heart failure. So kind of some summary points for heart failure. When you have a heart failure case, ask yourself, is this HFrEF or HFpEF or something in between? That's going to help you think through your therapy. So I would commit those sort of algorithms to memory, and then also learning your target doses for your RAS inhibitors and your beta blockers. Also, watch your patient's labs and vitals. So things like a high potassium or high creatinine might preclude your ability to use or titrate certain therapies. That can help you narrow down your answer choices. And then also watching your patient's vital signs, as this might also help you kind of narrow down what answer is best in your patient. Okay, so that is heart failure, and we will now move on to our second disease state, which is atrial fibrillation. I promise each one actually gets shorter as we go. So here we go with atrial fibrillation. So atrial fibrillation is our most common arrhythmia that requires hospitalization in the US. We know that it impacts up to 5 million Americans, and that the prevalence increases with age. When our patients are less than 60 years old, the prevalence is less than 1%, but by the time we hit 80 years of age, it's up to 10%. So it definitely increases with age. The main causes are things that cause atrial distension, so hypertension, cardiomyopathy, and lung disease, or things that cause high adrenergic tone. This is usually kind of more of an acute situation, like alcohol withdrawal, sepsis, or surgery. Atrial fibrillation frequently exists with other comorbidities, including heart failure, as well as valvular heart disease. And the reason we care about this so much is it is associated with heart failure, developing heart failure, and then also it is a risk factor for stroke. Remember that when we are looking at a patient with AFib, their atrial rates can actually get very, very high in the acute setting, but the ventricular rates can vary because our heart does have some ability to block atrial impulses from traveling into the ventricles. When you look at a patient's pulse, that's measuring kind of the ventricular rate, right? So also looking at their EKG. We typically classify AFib based on how long it has been going on. A patient with paroxysmal AFib is somebody who goes into atrial fibrillation for less than a week at a time, and then normal sinus rhythm is restored. A patient with persistent AFib has been in AFib for at least a week, and then long-standing persistent for at least a year. Permanent AFib is more of a decision between that patient and their provider to abandon attempts at restoring normal sinus rhythm. So instead, we are going to focus on symptom management and not necessarily try to restore normal sinus rhythm. When I think about managing AFib, I sort of think about two buckets. The first is, what am I going to do about the arrhythmia itself? And so we're talking about things like rate and rhythm control. And then the second is, I know that atrial fibrillation results in blood potentially pooling in the atria and developing into clots, which can cause strokes. So do I need to initiate antithrombotic therapy in my patient? When we think about rate control, pretty much all of our patients are going to be candidates for rate control. And then when we think about rhythm control, not everybody has to get rhythm control. You can just do rate control. So historically in our AFFIRM trial, we found that trying to do rhythm control in patients was associated with higher risk of hospitalizations, higher risk of arrhythmias like torsades. The thing to note is that this study is from 2002. It's older. It was mainly in people with persistent AFib, mainly in older adults. Recently, we had a new study called the East AFNet study, in which patients who had been in AFib for less than a year, so new AFib, they underwent a rhythm control approach either with drugs or with ablation. And in this study, we actually found a decrease in cardiovascular events. So because of that, the patients who are really going to be good candidates for rhythm control are those patients with a recent AFib diagnosis. They're the ones that are most likely to be able to restore normal sinus rhythm. And then anybody who we try a rate control approach, but we either can't get to our goal, or our patient still has AFib symptoms despite our rate control. Let's talk about rate control first. The first step is to decide what your patient's heart rate goal is going to be. So our goal resting heart rate of less than 80 beats per minute is called strict rate control. And this is a good option in patients who are having symptoms of their AFib, especially at higher heart rates. And then anybody with structural heart disease. So this is our patients with CHD or HFrEF, because we really need to slow that heart down so that it can adequately fill with blood and so that we can pump blood effectively throughout the body. However, we can try to go with a lenient rate control goal of less than 110 beats per minute in people who are asymptomatic with preserved systolic function. And so these are our two potential goals to pick from. And we try to reach them by starting different rate control agents, which we're going to choose based on our patient's concomitant disease states and their individual response. The two first-line drugs for rate control, we're going to pick one of these, is beta blockers or non-DHP calcium channel blockers. Both of these drug classes are useful in that they slow heart rate, and they also are effective at keeping heart rate down when the increases are associated with exercise. Kind of some of the key differences: beta blockers have more of an ability to potentially lower blood pressure if that's something that you are trying to achieve in your patient, especially labetalol and carvedilol because of that alpha blockade. And then beta blockers, as we already know, are safe for use in patients with heart failure with reduced ejection fraction. If you're picking a beta blocker for AFib alone, you can pick any beta blocker you want, but if your patient also has HFrEF, we need to stick with one of those three. For our non-DHP calcium channel blockers, verapamil and diltiazem, these may be preferred if your patient has severe lung disease, if we're concerned about beta effects in the lungs. And then these drugs, as you remember, are to be avoided in patients with heart failure with reduced ejection fraction because of their negative inotrope effects. So this might be an easy way to pick between two potential answer choices in a patient case. So whether or not they have heart failure. Our second-line therapies are digoxin and amiodarone. Digoxin is not really effective for rate control when it's used alone, but it's a little more effective when it's add-on therapy to our beta blocker or our calcium channel blocker. It might also potentially have a niche in patients with HFrEF if they might also benefit from it in that capacity. Amiodarone is really reserved for patients who are refractory to other attempts at rate control, and that's because, as we'll talk about soon, the list of side effects from amiodarone is so long, so we want to try to avoid using this if we don't really need to. Okay, so most of our patients, we're going to be rate controlling them with these drugs, and then we're going to be making a decision about rhythm control. If our patient is currently in atrial fibrillation, we want to try to restore normal sinus rhythm, we can achieve that through cardioversion. We can do this either electrically or with medications. I'm going to kind of go through these two slides pretty quickly because Dr. Dobesh in anticoag is going to actually talk about these in a lot more detail. But the important thing to note is that if you're cardioverting a patient, there's always a chance that they might have a clot in their left atrial appendage. If they've been in AFib for more than 48 hours, the chance of kind of developing that clot is much higher. If you cardiovert when that clot is present, they have a very high chance of having a stroke. And so if you are choosing to cardiovert your patient to attempt rhythm control, make sure that you are also considering, do I need acute antithrombotic therapy? And also, the way we would achieve this is if they've been in AFib for at least 48 hours, they may need to be on anticoagulants for at least 3 weeks before we attempt cardioversion. Cardioversion is designated by my non-copyrighted image of a lightning bolt for electrical and a pill for chemical. Or we could visually inspect with the TEE and see, does my patient have a clot in their left atrial appendage or their left atrium? If not, we can probably safely proceed with cardioversion. Regardless, the heart kind of becomes stunned after cardioversion, and so these patients are generally going to get anticoagulation for at least 4 weeks afterwards. And then otherwise, decisions about anticoag before and after this happens are based on CHADS VAS score. If we decide to attempt cardioversion with medications, there are 5 main drugs that have proven efficacy to treat early AFib. And so the mnemonic here is DIP-AF. It stands for dofetilide, ibutylide, propafenone, amiodarone, or flecainide. There are a couple agents that are less effective, disopyramide, quinidine, and procainamide. And then the guidelines do specifically say do not attempt to use digoxin or sotalol for cardioversion. Now, any of these drugs can be beneficial for AFib that's up to 7 days, but once we have persistent AFib, it's much harder to restore normal sinus rhythm. And there's actually only 3 drugs that have been shown efficacious in this capacity: dofetilide, ibutylide, and amiodarone. I remember those because the mnemonic would be DIA, which is Spanish for days. So people who have been in AFib for multiple days. Okay, so we are going to take like a little bit of a step back from atrial fibrillation specifically and review our antiarrhythmic drug classes in general. So not all of these are used for AFib, but they are all important to know for your exam. So I'm kind of going over a number of drug classes which are covered. Some of these are not covered in my chapter, but they're covered in Dr. Finks's chapter. And so some of these, again, are not for AFib, so just remember, we're reviewing the drug classes in general right now. These are classified according to our Von Williams classification. And so we have our class 1, which is our sodium channel blockers. A useful mnemonic for remembering these, it's all about burgers. So double quarter pounder for class 1A, which is disopyramide, quinidine, and procainamide. Lettuce mayo for class 1B, lidocaine and mexilotine. And then class 1C being flecainide and propafenone, fries please. We also have class 2, which is beta blockers. We're already very familiar with those, as well as class 4, which is calcium channel blockers. And then we also have our class 3, which is our potassium channel blockers. I like this mnemonic because there's a lot of antiarrhythmics that start with D, but the first 2 letters of the D words in this mnemonic correspond with the first 2 letters of the drug. So we have amiodarone, dronedarone, which matches with drooling, from a drooling dog is scary, dofetilide, which matches with dog, and then ibutylide and sotalol. Let's talk about each of these drug classes just in a little bit more detail. The main pearls you'll want to know about your class 1A drugs, for the most part, you're not going to be seeing these used commonly in atrial fibrillation. But as you'll notice, something they all have in common is the risk for potential torsades. So something to watch out for and monitor in QTC in these patients. Disopyramide also is associated with a lot of anticholinergic side effects, and it can also precipitate an acute decompensation of heart failure. Quinidine is not used a whole lot in practice because its use is very much limited by high rates of GI adverse effects like nausea, vomiting, diarrhea, up to 30%. And procainamide's main side effects to think about are a lupus-like syndrome, an acute decompensation of heart failure, and then if you are using procainamide, making sure you're checking for renal and hepatic dysfunction because dose adjustments will be required. We have our class 1B agents. The first one is lidocaine. These are mainly used for ventricular arrhythmias. Lidocaine comes for arrhythmia management in an IV-only formulation. Typically, you're going to see it being used maybe second line to amiodarone for VTAC. This does require hepatic and renal dose adjustments. And then we have mexilotine, which is sort of like an oral version of lidocaine, but we see a lot more CNS side effects with this drug, including tremor, dizziness, ataxia, and nystagmus. And then we have our class 1C drugs. Now these you will see used in AFib, flecainide and propafenone. So what these drugs have in common is that they can be used for the maintenance of normal sinus rhythm in a patient with paroxysmal AFib, meaning that they're dosed every day, or they can be used as a pill-in-pocket approach. So this is if patients are able to sense when they convert from normal sinus rhythm to AFib, and they can take this medication to try to restore normal sinus rhythm. These cannot be used in patients with structural heart disease. In fact, they can precipitate in a decompensation of heart failure. And we know from our CAST trial that we have increased risk of mortality. And so we try to avoid these. We certainly avoid these in those patients. These drugs increase the atrial to ventricular impulse conduction. So we can actually see a paradoxical increase in ventricular rate. And so because of this, when these are used for chronic therapy, then we want to make sure we have a rate control agent on board to help prevent that potential increase in ventricular rate. Things that make these drugs a little different from each other: flecainide has more ophthalmic and more neurologic side effects. I always just think of a fleck in the eye to help me remember the ophthalmic one. And then flecainide has drug interactions with digoxin, which might increase its levels by about 25%. Propafenone is similar to flecainide. It does actually have some beta blocking abilities as well, and so because of that, we can see more dyspnea and bronchospasm with it. We also see more GI side effects, and we see more significant drug interactions with digoxin, as well as some warfarin drug interactions. So we may need to dose reduce those agents if they're used at the same time. Okay, so that's class 1A, B, and C. Now we're gonna move to class 3. The most common drug that we probably all have the most experience with here is amiodarone. So amiodarone is very effective for conversion and maintenance of normal sinus rhythm in AFib or VTach. It comes IV and PO. It is up to 95% effective at preventing AFib recurrence. Amiodarone has features actually of all 4 drug classes, so we put it in class 3, but it has all 4 drug classes. I remember I had a professor in pharmacy school who called it a promiscuous drug, so it has effects on a lot of different receptors. One really unique thing about it is it's safe in heart failure. That's not common of a lot of antiarrhythmic drugs. If you're trying to use it for normal sinus rhythm in your patients, typically what we're going to do is try to achieve a loading dose of about a total of 10 grams. Depending where you work, you're going to see different ways that we achieve that, but generally speaking, we're trying to give about 600 or 800 milligrams a day for a few weeks and then slowly titrate down, and usual maintenance doses are somewhere around 200 milligrams daily. Amiodarone has a very long half-life, up to 52, 56 days with prolonged use, and it also has a number of drug interactions, both through CYP3A4 and P-glycoprotein. So it's important to keep in mind, even if you stop amiodarone on your patient, these drug interactions will persist for a couple of months. And probably the most famous thing about amiodarone is its very long list of toxicities in patients. So I do think it is a good idea to make sure you know how to monitor your patient for potential toxicities. So we would check PFTs at baseline, and then we would every year check a chest x-ray, and then as well as an EKG in these patients to monitor for pulmonary fibrosis and then QTc prolongation. We will check labs about every 6 months to check for the risk of hepatotoxicity and thyroid disorders. And then on physical exam, we'll watch for neuropathy, tremor, corneal deposits, and then photosensitivity or skin pigmentation. So some of these toxicities, like thyroid disorders, are due to amiodarone having this iodine moiety in it, amiodarone, right? And so there was some thought of, if we could invent a drug that's structurally very similar to amiodarone, but remove that iodine component, would we have a really effective drug with less side effects? And what we found is, kind of, right? So we invented dronedarone. And dronedarone is, again, structurally similar to amiodarone. It is only for maintenance of atrial fibrillation. We do not use this for cardioversion. In fact, there is harm if we try to use this in a patient with permanent AFib. It also has properties of all 4 drug classes, but it is unfortunately not as effective as amiodarone, so about 25% effective. It still has drug interactions, and some other things to know is that it is contraindicated in patients with heart failure, severe hepatic impairment, AV blocker bradycardia. Still has, again, drug interactions. And we do not use this in patients with a history of amiodarone-induced liver or lung toxicities. So if you're having to switch from amiodarone to something else, this is not your choice. It's contraindicated in pregnancy. And then something very common with all these class 3 agents is that the QTc risk and the risk of torsades can be really high. So contraindicated in patients with a QTc of 500 or more. The third agent here is dofetilide. So dofetilide is about 50 to 60% effective at maintaining normal sinus rhythm, and it can actually also be used for cardioversion. Dofetilide has very significant QT prolonging effects that are proportional to its plasma concentrations. So because of this, we start dofetilide in the hospital with a 3-day stay. And we check the QT interval, the QTc interval after the first 5 doses, 2 or 3 hours after the first 5 doses. And we make dose adjustments, or at sometimes we have to discontinue therapy based on how much longer the QTc interval gets with the use of dofetilide. So it's contraindicated if the baseline QTc is more than 440, and if at any point it exceeds 500, the recommendation is to stop the drug. It has a number of drug interactions, both through CYP3A4 and also through competition for tubular secretion, so things like migestrol, trimethoprim, verapamil, cimetidine. Dofetilide requires renal dose adjustments and is contraindicated in a creatinine clearance of less than 20. And the main side effects are dizziness, headache, and then of course the concern for ventricular arrhythmias, which were very high in some studies. So if you have a patient on dofetilide, it is so important to really stay on top of their electrolytes and make sure we keep their potassium at least 4 and their magnesium at least 2. Next, we have ibutylide. Ibutylide only comes IV. I remember ibutylide IV. And so for that reason, it is only used for cardioversion. We're not going to send someone on ibutylide long term. The main things to know about ibutylide is it does still have some drug interactions with CYP3A4, is contraindicated in heart failure with reduced ejection fraction, and is contraindicated with a QTc greater than 440. And then finally, we have sotalol. Sotalol is a class 3 antiarrhythmic, but it ends in lol. It also has beta-blocking properties. It's 50 to 60% effective at maintaining normal sinus rhythm. Again, it is not used for cardioversion. Similar to dofetilide, it causes a QTc prolongation proportional to its dose, so it is also recommended to start with an inpatient hospital stay. And it's contraindicated with a baseline QTc more than 450. Sotalol has a lot of renal dose adjustments, and I actually put them in here specifically just to show you that the renal dose adjustment actually starts pretty high. At a creatinine clearance of 60, we already have to start making renal dose adjustments to avoid the risk of significant QTc prolongation. This is contraindicated in HFrEF, and of course we're concerned about torsades and then also potentially bradycardia, mainly because of that beta blocking ability, and the risk of that would be additive with other therapies. Okay, so we just talked about all the antiarrhythmics. Now let's pull it back together to AFib. What do I need to know for AFib with these drugs? So you might be asked to pick the best antiarrhythmic for your patient. And so the first question I would think through is, does my patient have structural heart disease? This algorithm is for the maintenance of normal sinus rhythm. And so you can see if your patient does not have structural heart disease, we have 5 main first-line options, and then amiodarone is second line. So our first-line options are dofetilide, dronedarone, and sotalol, all from class 3. The only thing that's missing is amio because it's second line, and ibutylide because it's IV. And then flecainide and propafenone, which are our class 1C drugs. So any of those can be picked in a patient without structural heart disease. At any point in time, your patient can pursue catheter ablation for rhythm control. That's why this is included in, this is a diagram from the guidelines. If your patient does have structural heart disease, then the question is, do they have CHD or heart failure? If they have CHD, then our options are limited first line to dofetilide, dronedarone, and sotalol. And then again, amio being second line because of all of its toxicities. So the difference between no structural heart disease and CHD is that we pulled out the class 1C drugs. We don't use those. And then for heart failure, there's only 2 drugs that are safe and effective for use in these populations. So amiodarone and dofetilide, those are the only 2 options to consider. The other things I would think about if you're choosing your antiarrhythmic are, what is my patient's renal function? That might preclude the use of some of these drugs. What drug interactions do I need to watch out for? There's a ton with CYP3A4 and P-glycoprotein, so looking for that. Are there any specific adverse effects that would be particularly problematic in this patient? So for example, on the right, if they have severe pulmonary disease, you might want to avoid agents like amiodarone and dronedarone, and then also caution with propafenone because remember it has that beta blocking, more bronchospasm properties. Check your QTc, what is safe to use? Hospitalization, is it realistic to admit my patient for dofetilide or sotalol right now? And then also monitoring for hypokalemia. We just really want to keep on top of these electrolytes, maintaining our potassium at least 4, and don't use sotalol or dofetilide if your patient has chronic hypokalemia. Okay, anticoagulation, again, Dr. Dobash is going to go over this. I'm not really going to spend a lot of time on this, except that don't forget to see if your patient needs antithrombotic therapy by calculating their CHA2DS2-VASc score. And we do know that if the score is at least 2 in men or 3 in women, they certainly warrant anticoagulation therapy. And anything less than that, you can see the guidance here, and Dr. Dobash will go over this in a lot of detail with you. So that brings us to our AFib case here. We have PM, a 52-year-old man with a history of hypertension and a TIA. He's been complaining of several weeks of a fluttering feeling in his chest, and he's complaining about difficulty making his 3-hour drive to visit his PCP. His medications are just low-dose aspirin and then metoprolol tartrate 50 BID. You check labs, they're all within normal limits. You see that his blood pressure is at goal. His heart rate's 74 beats a minute, but on EKG you find that he has an irregular rhythm. He has no P waves, which is essentially diagnostic for atrial fibrillation. So our question is, which of the following approaches is most appropriate for managing his AFib? Okay. All right, so the majority of you chose answer choice D, which is to begin dabigatran. So I agree with you here. This patient's CHA2DS2-VASc score is 3, so he had the history of the TIA, which is 2 points, and he has hypertension, which is 1 point. So he is going to warrant antithrombotic therapy, anticoagulant therapy. Generally speaking, DOACs are preferred over warfarin, and especially in this patient because he's complaining of trouble making it to clinic visits. So INR monitoring might be particularly problematic. So with regards to answer choice A, this patient's rate is well controlled. We don't necessarily need to add any additional AV blockade. Kind of same with B, and we want to avoid using diltiazem and beta blockers together at the same time. So if this patient's symptoms continue to be really problematic for him and he is at his heart rate goal, this might be, a candidate to be thinking about a rhythm control approach. And then our final AFib case, HD, a 67-year-old man. He presents to the clinic after he went to the ED for increased fatigue on exertion, palpitations, and lower extremity edema. We know he has AFib. He's had it for 4 years. He also has a history of hypertension, and his current medications are ramipril, sotalol, digoxin, and warfarin. His blood pressure is 115/70, heart rate is 88. His labs are normal, including an INR at goal of 2.8, and his ECG shows AFib. So because of his new symptoms that he had of lower extremity edema, fatigue on exertion, you decide to check an echocardiogram, and you find that his EF is now 35 to 40%. So the team says, I really want to continue doing a rhythm control approach on this patient, but I know that things have changed now. What is going to be the best option for continuing a rhythm control approach? All right, so all of you picked C, which is to discontinue sotalol and begin amiodarone. So this patient now has heart failure with reduced ejection fraction. Because of that, we know that sotalol is no longer an option in this patient. We have to discontinue it, which makes D incorrect. Answer choice A, discontinue sotalol and begin metoprolol. Metoprolol is not necessarily an inappropriate, drug in this patient, although we probably don't want to start a beta blocker where they're acutely fluid overloaded and acutely having heart failure symptoms. So that's probably not the best choice. Also, you're specifically being asked to pick a rhythm control approach, so some test psychology there. A is not the right answer. So you're really stuck choosing between dronedarone and amiodarone, and we know just looking at our patients with structural heart disease that amiodarone is the only safe option in this patient, and the only other choice that would have been reasonable would have been dofetilide. Good job. Key points, key takeaways. If your patient's in acute AFib, you're really at that moment just focusing on their ventricular rate. You're considering it acceptable if we can get it less than 110 and they're asymptomatic. And if they're unstable, they might require synchronized cardioversion and anticoagulation. Chronic AFib, which is probably where most of your questions will come from. Remember, we've got to think through the AFib part itself. So rate control, what is their goal? How do I get there using beta blockers and calcium channel blockers first line? Do they need rhythm control? If so, how do I pick the best drug for that patient? And then do I need to anticoagulate my patient and figure that out using the CHA2DS2-VASc score? Okay, so next we're going to go into hypertension, and this one will be relatively short. Hypertension is now defined as a systolic blood pressure of 130 or greater or a diastolic blood pressure of 80 or greater. Because of this threshold being lowered kind of a few years ago, 46% of Americans now have hypertension, so that makes it the most common chronic disease in the US. And hypertension is problematic because it's a major modifiable risk factor for cardiovascular disease. So you can see our blood pressure categories listed for you here. Once our patient's diagnosed with hypertension, we need to figure out if they have stage 1 or stage 2 hypertension. So stage 1 is that systolic threshold of 130 or greater, or the diastolic threshold of 80 or greater. Stage 2, you add 10 to both of those numbers. So a systolic blood pressure of at least 140 or a diastolic of at least 90. When we are managing hypertension, lifestyle modifications, of course, are going to be the backbone, the thing to do first. And we know that weight reduction and diet probably have the most impact in terms of diet and lifestyle modifications to help lower blood pressure. But reducing sodium intake, potassium supplementation, being active, and moderating alcohol consumption all also have pretty significant impacts on blood pressure. With regards to when to start medication therapy, we determine this by figuring out what our treatment threshold would be for that patient. So the treatment threshold just means at what blood pressure do the guidelines say I start therapy. So this is all based on the ACC/AHA hypertension guidelines. Generally speaking, if your patient has other cardiovascular or renal comorbidities, our treatment threshold is 130 over 80. So once our patient reaches that blood pressure, it's recommended to start drug therapy. So exceptions of patients who have a higher threshold would be if you have a patient with no clinical CVD and you calculate their 10-year ASCVD risk and you find it to be less than 10%, we can withhold drug therapy until they reach stage 2 hypertension. But patients that have clinical cardiovascular disease or their calculated risk is greater than 10%, the threshold's 130 over 80. Patients with CKD, diabetes, heart failure, PAD, these patients are all going to have a 130 over 80 threshold. Folks that have had a stroke in the past, the treatment threshold is actually 140 over 90 due to insufficient evidence to target lower, with the exception being patients with a history of lacunar strokes, where the threshold is still 130 over 80. And I also want to draw your attention to the last row. This is a very controversial point, but the ACC/AHA guidelines do say that the target blood pressure for older ambulatory community living adults is, the treatment threshold is a systolic of 130. So when we're thinking about starting drug therapy for stage 1 hypertension, remember, not everybody has to be treated. That's not everybody's treatment threshold. But if your patient does need treatment for stage 1 hypertension, we usually start therapy with 1 drug. If your patient has stage 2 hypertension, the guidelines do say it's okay to start 2 drugs right away. Most likely this patient is going to need 2 drugs, so we can just pick 2 from the beginning. I think this is your money slide in terms of questions that you might want to anticipate for managing hypertension. How do you pick the best drug for your patient? Well, it's really going to be guided on their comorbidities. So I've tried to sort of arrange these in terms of first-line and second-line drug therapy based on comorbidities. I actually want to start with the HFrEF because we've just talked about HFrEF extensively. So you can see if your patient has hypertension and they have HFrEF, you're obviously going to pick the drugs from the HFrEF algorithm that also lower blood pressure, right? So ACEs, ARBs, ARNIs, MRAs, beta blockers, and diuretics, those would be considered first line. If you look at the HFpEF algorithm, remember the hypertension guidelines came out before the new heart failure guidelines. So the hypertension guidelines do still kind of leave your algorithm like this. I would recommend doing what the new heart failure guidelines say to do for HFpEF, which is to consider diuretics, MRAs, ARBs, and ARNIs for these patients. Other comorbidities, a history of stroke or TIA, we know that thiazides and ACEs and ARBs may confer a mortality benefit in those populations, so starting there. CHD, ACEs, ARBs, beta blockers. You're gonna learn about how to manage CHD from Dr. Finks here soon, so you'll see why we pick some of these therapies. If your patient has diabetes or CKD and they have albuminuria, then you want to select an ACE or an ARB for management of those patients. If your patient doesn't have any of these comorbidities, what do? Well, there's 3 main drug classes that the guidelines recommend picking from, and they're listed at the bottom for you: thiazides, ACEs or ARBs, and calcium channel blockers. So you would want to pick one of those. You would also defer to that list of 3 drug classes if you have exhausted your options treating your patient's comorbidities and you need an additional drug. I do want to note the guidelines say in Black adults with hypertension, but without a compelling reason to use an ACE or an ARB, if you're selecting from those 3 main drug classes, preference should be given to thiazide-type diuretics or calcium channel blockers, which we know are more effective at lowering blood pressure in that population. And then again, if your patient has stage 2 hypertension, you can start 2 drugs right away. In fact, most patients with hypertension are going to need at least a 2-drug regimen. So we're gonna wanna monitor for efficacy at 4 weeks. We can check sooner if we want, we can titrate sooner if we're concerned. But basically what we'll do is we'll take the drug that we started, we'll titrate to a reasonable dose, and if we're still not where we wanna be, we'll add another drug on, right? Just following our algorithms. So our hypertension case, we have TJ, 58-year-old African-American woman presenting for routine follow-up, has a history of COPD and is a current smoker. Her blood pressure today is 138/88. This is the same as her blood pressure at her last clinic visit. Her heart rate is 77. She takes a couple inhalers, but that's it. Her labs are listed and are normal, including a potassium of 4 and a creatinine of 0.8. So you calculate her 10-year ASCVD risk and find it to be 12%. Which of the following approaches is going to be most appropriate for managing her hypertension? Excellent, I agree with you. Answer choice B, we're going to begin lifestyle modifications and we're gonna add amlodipine 5 a day. So this is the best choice for this patient. If we look at this patient, we know that her 10-year ASCVD risk is more than 10%, so her treatment threshold is gonna be 130/80, and so we're gonna start drug therapy for that reason. So answer A would be wrong because there's no drug therapy listed. We also know she's a stage 1 hypertension patient, so we don't have to start with 2 drugs for her, making D incorrect. So we're really picking between amlodipine and lisinopril. Because this patient is African American, amlodipine is the preferred drug based on the guidelines due to a more potent response to this drug class. If this patient were not African American, then answer choice C would have also been correct. Key points for hypertension: address lifestyle modifications. They can do quite a bit for lowering blood pressure. When we're picking medication therapy, first-line medications if no concomitant disease states are ACEs, ARBs, calcium channel blockers, and thiazide diuretics. But we will use our patients' concomitant diseases to guide our therapy if they have any comorbidities. If our patient is African American, picking between calcium channel blockers or thiazides unless there's a compelling indication to pick something else. And then stage 2 hypertension, considering a 2-drug regimen is appropriate. Okay, so that brings us to our last topic today, which is dyslipidemia. Management of dyslipidemia, we're always going to want to address diet and lifestyle first. Lifestyle modifications include a heart-healthy diet, regular exercise, maintaining a normal weight, and of course smoking cessation, as this will help reduce ASCVD risk. When we start drug therapy, we're always gonna start with statin therapy. Statins always come first in our hyperlipidemia guidelines. And this is because we have a lot of trials showing us that statins reduce major coronary events, CHD mortality, stroke, total mortality, all sorts of cardiovascular endpoints. So these have really become our cornerstone of therapy. What I think you need to make sure you know about statins is their intensities. So we divide statins into low, moderate, and high intensities. You're gonna wanna memorize which drugs and doses are each. So I think it's easiest to memorize high intensity statins, atorvastatin 40 and 80, rosuvastatin 20 and 40, and then maybe memorizing your low intensities and knowing everything else is somewhere in between. Although our guidelines never recommend a low intensity statin. They recommend moderate or high in different situations. Okay, these next few slides I think are much easier to read in your workbook where I have this whole algorithm on one page. It's a lot easier to follow, but we'll go through pieces of it. If you're gonna start statin therapy, you're gonna wanna think about what patient management group am I looking at? And you're gonna wanna ask the questions in this order. So your first question is going to be, does my patient have ASCVD? if they do have ASCVD, for the most part, they're going to qualify for a high-intensity statin. The only exception in our guidelines is if they're considered not very high risk and their age is greater than 75. What does high risk mean? It means if they have a history of multiple ASCVD events, or they have ASCVD plus they have multiple high-risk conditions. Our high-risk conditions are listed in the footnotes, but it's a lot of comorbidities. It's things like hypertension, heart failure, CKD, smoking, all sorts of things. So most of our patients are going to end up qualifying for a high-intensity statin if they have ASCVD. If your patient does not have ASCVD, the next question is, do they have severe hypercholesterolemia, meaning an LDL-C of at least 190? Here, the recommendation is to use a maximally tolerated statin therapy, so really a high intensity, if at all possible. The third group is patients with diabetes. So here you're going to want to say, how old is my patient? If your patient falls between 40 and 75 years of age, they qualify for a moderate intensity statin, and then a high intensity statin is reasonable in patients who have multiple ASCVD risk factors. Younger patients, it's really a benefit-risk discussion, so they may be candidates for statin therapy after you talk about that with your patient. And then our older adults, if they're already on a statin, just continue it. But if they've not been started on a statin yet, this is again going to be a benefit-risk discussion. And then if they don't have any of those conditions, then what we're going to want to do is calculate their 10-year ASCVD risk score and classify them as low, borderline, intermediate, or high risk, and use that to guide our statin therapy. Folks who are considered low risk with a risk of less than 5%, this is going to be another situation in which lifestyle modifications alone are probably sufficient, but you'll want to readdress in 4 to 6 years. Borderline risk, if multiple risk enhancers are present, you might want to consider a moderate intensity statin. And then intermediate risk, get moderate intensity statins, and high risk, get high intensity. So think moderate, get high, get high. Okay, so I keep mentioning this ASCVD risk assessment. This is a pooled cohort equation. There's a lot of websites online where you can plug in patient variables like age, sex, race, lipid panel, diabetes, smoking status, blood pressure, and it will tell you your patient's 10-year risk of having an ASCVD event. On your test, you're not going to be expected, I wouldn't imagine, to calculate this because it's not an equation you can memorize, but interpreting it would be something you may be held responsible for on an exam. So this is, again, specifically for primary prevention. You wouldn't calculate this in someone that already has ASCVD. And it is verified in patients aged 40 to 79 years. So if we've started a statin, we'll recheck our fasting lipid panel in 1 to 3 months and see if we've achieved our goal. If not, we can go up on the dose. And if we still don't get to where we want to be, we can consider adding on non-statin therapy. And for safety, monitoring liver function tests, alanine aminotransferase, if it's 3 times the upper limit of normal chronically, then we might want to adjust that. You really only have to check CK if it's indicated if your patient's having muscle symptoms. And then, of course, there's a ton of drug interactions. There's a big table in the workbook to be familiar with. Non-statin therapy. There's really 2 main drugs or drug classes that the guidelines recommend. The first is ezetimibe, which lowers LDL by about 20%, and it does this by inhibiting cholesterol absorption in the gut. It's generally pretty well tolerated, watching for headache, rash, and then checking LFTs if it's being used concomitantly with a statin. And the reason that ezetimibe is included in the guidelines is it does have some positive cardiovascular data, so the Improve It trial, which showed a reduction in death and cardiovascular events after ACS when added to statin therapy. The other drug class is our PCSK9 inhibitors. So these are evolocumab and alirocumab. These have very potent LDL lowering effects of 50 to 60%. They are monoclonal antibodies that essentially increase cholesterol clearance from the liver. The main side effects here are injection site reactions. So you'll note these are subcutaneous injections given every 2 or 4 weeks, and then respiratory infections. And these have been shown to improve cardiovascular outcomes in a number of recent clinical trials. So the way our guidelines say to consider non-statin therapy is they say we'll always think about ezetimibe first, and then we can consider adding on a PCSK9 inhibitor after that if we still need to. And this is also guided by these different benefit groups. So you can see we've already talked about the statin therapy column, The next column is, when will we consider ezetimibe therapy? So for patients with ASCVD, the guidelines say if the LDL-C is at least 70, you can consider adding on ezetimibe therapy second line. And then in our patients who are very high risk, if we still don't get to goal with ezetimibe, we can add on a PCSK9 inhibitor. In our severe hypercholesterolemia patients, the goals from the guidelines are an LDL-C reduction of at least 50% or a threshold of at least 100, where you could add on ezetimibe, and then you can consider adding on a PCSK9 inhibitor. They give some very specific recommendations, which are just essentially the inclusion criteria from the specific studies, but PCSK9s can be considered add-on therapy in patients with severe hypercholesterolemia. Diabetic patients, they only recommend ezetimibe. So there's no role for PCSK9 inhibitors if their benefit group is diabetes. And they specifically recommend it in patients between age 40 and 75 years of age who have a 10-year ASCVD risk of at least 20%. And then for primary prevention, again, you see there's no role for PCSK9 inhibitors here, but in some cases you might consider ezetimibe add-on therapy. Again, it's a very specific recommendation, and it's based on inclusion criteria from a trial, but you can consider adding it on in our intermediate risk patients for primary prevention. So our hyperlipidemia case, we have MM, a 63-year-old white woman presenting to clinic. She's just done 6 months of diet and exercise therapy for dyslipidemia. She has hypertension, diabetes, and asthma. She smokes and drinks 3 beers a day. She's on albuterol, lisinopril, metformin, linagliptin, and calcium carbonate. Her blood pressure is 134/84, and her heart rate is 75. You check her labs, you note an LDL-C of 134 on her lipid panel, and you calculate her 10-year ASCVD risk, find it to be 27.8%. So which of the following next steps is most appropriate for this patient? Great, so I agree with you. Answer choice C, initiating a high-intensity statin. This patient's management group is a patient with diabetes between 40 and 75 years of age, and she also has multiple ASCVD risk factors. So she has smoking, she has a low HDL, she has hypertension, so she would likely benefit from a high-intensity statin. So low intensity is never gonna be the answer because that's not a recommendation anywhere in the guidelines, and she has reasons to not be on a moderate intensity, but instead high. And then answer choice D is incorrect because the guidelines say start with the statin and then consider ezetimibe as add-on if you don't reach your goals. Okay, in our last couple of minutes, I have 3 minutes, we will quickly go over hypertriglyceridemia. So the guidelines specifically talk about management of hypertriglyceridemia with the primary goal here really of preventing pancreatitis. We have a bunch of trials. We have drugs that we know lower triglycerides, but we don't have a lot of trials that show us that specifically targeting triglycerides is beneficial from a cardiovascular standpoint, which is why the primary focus here is preventing pancreatitis. So the first thing that you'll want to do is evaluate your patient for potential secondary causes. So these can be metabolic things, they can be like diet things, like a high trans fat or saturated fat diet, things like hypothyroidism, biliary obstruction, and then of course we know there's a lot of drugs that can increase triglyceride levels, so things like glucocorticoids, cyclosporin, diuretics, things like that, monitoring for those potential causes and addressing them first. If your patient has moderate hypertriglyceridemia, in addition to addressing their lifestyle factors and comorbidities, we may want to also discontinue any of these medications which can increase triglycerides. If our patient has severe hypertriglyceridemia, meaning triglycerides of at least 500, then you'll see if they stay persistently elevated and your patient's ASCVD risk is at least 7.5%, the recommendation is if they're not already on a statin, it's maybe reasonable to start one now, or if they are already on a statin, can I go up on the dose or the intensity of that statin? They do also say it is reasonable to initiate a fibrate or an omega-3 agent to prevent pancreatitis, and especially so if your patient's triglycerides are at least 1,000. I did want to include just a quick slide on icosapent ethyl because the guidelines specifically mention this drug, and it was studied fairly recently in the REDUCE-IT trial, not for severe hypertriglyceridemia, but it is what is referenced. So this is an omega-3 fatty acid product, and it's unique in that it only contains EPA. It does not contain DHA. And so in a recent REDUCE-IT trial that looked at patients with a triglyceride range of about 150 to 499, they dosed this agent at 2 milligrams twice daily, and they did find a reduction in the composite of cardiovascular death, non-fatal MI, non-fatal stroke, revascularization, and unstable angina. So for this reason, the guidelines do specifically recommend this drug as one that you could consider in this patient population. So key points, lifestyle modifications are the backbone. Treatment decisions are based primarily on cardiovascular risk. Weak LDL and non-HDL recommendations do exist for goals that we want to achieve. Statins are the cornerstone. Know your intensities. Know which patients should get what intensity. Remember that not all patients with comorbidities necessarily have to be on a statin, so CKD alone or heart failure alone is not enough that they necessarily need to be on a statin. And then watch for drug interactions and know when to add on additional therapy. Okay, so if that felt like a lot, it's because it was, but I think you all are ready now to manage your chronic cardiology patients. I think we're out of time for questions, but I think we have a break, and so I'll be available for that.